Bipolar disorder, an ancient force, a hidden war. Deep within the human skull, an electrical storm rages, neurons firing, chemicals surging, consciousness itself splitting between two impossible extremes. One moment, euphoria so intense reality dissolves into cosmic significance. The next, darkness so complete that hope becomes a forgotten language. For millennia, this pattern has terrorized civilizations, baffled healers, and claimed countless lives. But why does it exist? What transforms a brain into a battlefield where mood becomes weapon, where sleep vanishes for days, where suicide whispers in the shadows? From the first Greek observations to cutting-edge neuroscience, from asylum horror to genetic revelation, this is the untold story of humanity's most dramatic mental condition. Witness the biology of extremes. Feel the weight of generations struggling between mania's seductive power and depression's crushing grip. Discover why evolution preserved this devastating pattern, and why some of history's greatest minds carried it. This is not just science. This is the raw, unfiltered truth about living with a brain that can soar to godlike heights or plunge into absolute despair. This is the complete science of bipolar disorder. Before we begin, if you enjoy these types of interesting science topics, hit the like button, comment, and tell us where you are listening from. If you'd like to hear more stories like this, you know what to do. Simply subscribe. The human mind is an electrical storm contained within bone. Every thought, every emotion, every flicker of consciousness emerges from billions of neurons firing in precise choreography. Within this vast neural architecture lies a delicate system responsible for regulating mood, the emotional color that tints our perception of reality itself. For most people, this system maintains equilibrium, adjusting smoothly to life's fluctuations. But in some minds, something fundamentally different unfolds. The system that governs mood begins to swing between extremes, creating a pattern so distinctive that it has been recognized, feared, and misunderstood across millennia of human history. Long before modern psychiatry, before brain imaging or neuroscience, healers and philosophers documented the existence of people who cycled through profound states of opposing emotion. In ancient Greece, physicians observed individuals who would oscillate between melancholia, a deep, immobilizing sadness, and what they called mania, a state of excessive energy and disturbed thought. The Greek physician, Aretaeus of Cappadocia, working in the 1st century of the Common Era, wrote detailed descriptions of patients whose dispositions would shift from withdrawn despair to frenzied agitation. He believed these were not separate afflictions but two faces of the same underlying condition. Across the world, traditional healing systems recognized similar patterns. Chinese medical texts describe disturbances in the balance of energies that could manifest as emotional extremes. Indian Ayurvedic practitioners documented mood states that swung wildly beyond normal human experience. Medieval Islamic physicians built upon Greek knowledge, creating detailed taxonomies of mental states that included cyclical mood disorders. What united these observations across cultures and centuries was the recognition that some human minds contained an inherent instability, a tendency toward oscillation that seemed built into their very architecture. The condition we now call bipolar disorder represents one of the most profound mysteries of human neurobiology. Why would evolution preserve a pattern of brain function that creates such dramatic swings in mood and perception? The answer may lie in the complex relationship between mood regulation and survival. The systems that govern our emotional states evolved to help us respond to environmental challenges. Energy, motivation, confidence, these emerge from neural circuits that push us toward action. Caution, reflection, withdrawal, these emerge from circuits that pull us toward safety and conservation. In most brains, these opposing forces maintain a dynamic balance. But in the bipolar brain, the regulatory mechanisms that should modulate these systems appear to function differently, allowing mood states to amplify beyond typical boundaries. Consider the evolutionary context. Our ancestors faced environments where both intense action and careful restraint were necessary for survival. The ability to experience elevated energy and reduced need for sleep might have provided advantages during critical periods: hunting, migration, conflict, reproduction. Similarly, the capacity for deep withdrawal might have facilitated recovery, reflection, and the conservation of resources during harsh seasons. Some researchers have proposed that the genetic variations underlying bipolar disorder may have been preserved precisely because they occasionally provided adaptive advantages, even as they created vulnerability to destabilizing mood extremes. The condition appears across all human populations, in every culture studied, at rates suggesting deep evolutionary roots. While the exact prevalence varies by region and diagnostic criteria, the fundamental pattern dramatic oscillation between elevated and depressed mood states emerges universally. This universality suggests that bipolar disorder is not a modern phenomenon or a product of contemporary stress, but rather an ancient variation in human brain function, as old as our species itself. The brain regions most centrally involved in mood regulation include structures deep within the cerebral architecture, the limbic system, which processes emotion and motivation, and the prefrontal cortex, which exerts control and modulation over emotional responses. These regions communicate through intricate networks of neurons that release chemical messengers, creating the biological substrate of feeling itself. In bipolar disorder, something about this communication system functions differently. The precise nature of this difference remains one of neuroscience's most compelling questions, but the existence of the pattern is undeniable. What makes bipolar disorder particularly fascinating from a scientific perspective is its episodic nature. Unlike conditions that present with constant symptoms, bipolar disorder unfolds as a series of distinct mood episodes, separated by periods of relative stability. This suggests that the underlying biology involves not a simple deficiency or excess of any single factor, but rather a dysregulation of dynamic systems circuits that should cycle smoothly, but instead swing toward extremes. The brain, in essence, loses its ability to maintain homeostatic balance in the domain of mood. Ancient observers had no knowledge of neurons or neurotransmitters, yet they recognized something essential: that certain minds contained an inherent propensity for emotional extremes, and that this propensity seemed to run in families. Modern genetics has confirmed this intuition. Bipolar disorder clusters strongly within families, with inheritance patterns suggesting complex genetic architecture involving multiple genes, each contributing small effects that accumulate to increase vulnerability. If one identical twin develops bipolar disorder, the other twin faces a risk many times higher than the general population, yet not certainty, indicating that genes provide susceptibility rather than destiny. The question of why this pattern exists leads us into profound territory. Perhaps the capacity for extreme mood states represents a price our species pays for the gift of emotional complexity itself. Human consciousness allows us to experience joy, creativity, connection, and meaning at depths no other species approaches. But this same complexity creates vulnerability. The systems that generate our richest experiences can, under certain conditions, generate our most devastating ones. Bipolar disorder may represent an extreme variation within the spectrum of human emotional possibility, a reminder that the architecture enabling our highest capacities also contains the seeds of profound suffering. As we begin this journey into the science of bipolar disorder, we must hold two truths simultaneously. First, this condition causes immense suffering and requires serious medical attention. Second, understanding it requires us to grapple with fundamental questions about human consciousness, evolution, and the nature of emotion itself. The story of bipolar disorder is ultimately a story about what it means to be human, to possess a mind capable of both soaring heights and crushing depths, and to search for stability within systems inherently prone to flux. The formation of bipolar disorder begins long before any mood episode announces itself. It begins in the intricate dance between genes and environment, between inherited vulnerability and lived experience, between brain development and the chemical systems that will eventually govern mood. To understand how this condition takes root, we must journey into the realm of human genetics, neurodevelopment, and the mysterious process by which a brain becomes primed for mood instability. Every human being inherits approximately 20,000 genes from their parents, a vast instruction manual written in the language of DNA. Among these genes are hundreds that influence brain development, neurotransmitter function, and stress response. For most people, the particular combination of genetic variants they inherit creates a brain that regulates mood within normal parameters. But for some, the genetic inheritance includes multiple subtle variations that, when combined, increase vulnerability to mood dysregulation. No single gene causes bipolar disorder. Instead, research has identified numerous genetic regions associated with increased risk, each contributing a small effect. These genes influence diverse aspects of brain function, how neurons communicate with one another, how brain structures develop and connect, how the body responds to stress, how circadian rhythms are maintained, how energy metabolism functions within brain cells. The pattern that emerges from genetic studies is one of cumulative risk, multiple small genetic variations that, together, shift the probability that a person will develop the condition. Family studies reveal the powerful role of inheritance. If both parents have bipolar disorder, their children face dramatically elevated risk. If one parent has the condition, risk increases substantially, but not overwhelmingly. Siblings of people with bipolar disorder carry heightened vulnerability. Extended family members show elevated rates compared to the general population. This clustering within families provided the first clear evidence that bipolar disorder has biological roots, though the specific mechanisms remained mysterious for generations. Yet genetics alone cannot explain who develops bipolar disorder and who does not. Identical twins share virtually the same DNA. Yet if one twin develops the condition, the other has roughly a 50% chance, high compared to the general population, but far from certain. This tells us that genes create vulnerability, but other factors determine whether that vulnerability manifests as illness. The brain that will eventually develop bipolar disorder is shaped not only by inherited DNA, but by the environment it encounters during critical developmental periods. Brain development is an extraordinarily complex process that begins in the womb and continues through early adulthood. During this extended period, the brain constructs itself through carefully orchestrated stages. Neurons multiply, migrate to their destined locations, extend long projections to connect with other neurons, refine these connections through use, and eventually stabilize into mature circuits. Throughout this process, environmental factors, nutrition, stress, toxins, infections, trauma, can influence how development unfolds. Some research suggests that disruptions during critical developmental windows may contribute to the vulnerability that later manifests as bipolar disorder. The adolescent and young adult years represent a particularly crucial period. This is when the prefrontal cortex, the brain's executive control center, undergoes its final major phase of development. It is also when most cases of bipolar disorder first emerge. The timing is not coincidental. The prefrontal cortex helps regulate emotional responses generated by deeper brain structures. When this regulatory system is still maturing, mood states may be more prone to destabilization. Combined with genetic vulnerability, hormonal changes during puberty, increased stress, and often the first experiences with substances that affect brain chemistry. Adolescence creates conditions where latent vulnerability can transform into active illness. The chemistry of mood depends on neurotransmitters, molecules that neurons use to communicate with one another. Several neurotransmitter systems are implicated in bipolar disorder, including dopamine, which influences motivation and reward, serotonin, which affects mood and impulse control, and norepinephrine, which regulates arousal and stress response. In the brain predisposed to bipolar disorder, these chemical systems may function differently from the start, or they may develop differently in response to early experiences. The result is a neurochemical landscape where mood states can become amplified and prolonged, rather than remaining transient and proportionate. Stress plays a complex role in the emergence of bipolar disorder. While stress does not cause the condition in people without underlying vulnerability, it can act as a trigger that unmasks latent susceptibility. Significant life stressors, loss, trauma, major transitions, often precede the first mood episode in people who will go on to develop the full disorder. The relationship between stress and mood dysregulation appears to involve sensitization. Early episodes may require significant triggers, but over time, the brain becomes more prone to mood episodes, even without obvious precipitants. This phenomenon, sometimes called kindling, suggests that having mood episodes changes the brain in ways that make future episodes more likely. Sleep and circadian rhythms represent another critical factor in the formation of bipolar disorder. The human brain contains an internal clock that regulates sleep-wake cycles, hormone release, body temperature, and countless other physiological processes. This circadian system is intimately connected to mood regulation. Disruptions to sleep, whether from shift work, travel across time zones, substance use, or stress, can destabilize mood in vulnerable individuals. Many people with bipolar disorder report that their first mood episode followed a period of severely disrupted sleep. The relationship is bidirectional. Mood episodes disrupt sleep, and sleep disruption can trigger mood episodes. Substance use during adolescence and young adulthood can also influence the emergence of bipolar disorder. Alcohol, cannabis, stimulants, and other psychoactive substances affect the same neurotransmitter systems implicated in mood regulation. In a brain already vulnerable to mood instability, substance use may hasten the onset of symptoms or trigger the first manic or depressive episode. This creates a tragic irony. Young people with emerging bipolar symptoms may turn to substances to manage uncomfortable mood states, inadvertently worsening the very problem they are trying to solve. The brain that develops bipolar disorder is not structurally identical to the typical brain. Imaging studies have revealed subtle but consistent differences in brain structure and function. On average, people with bipolar disorder show differences in the size and connectivity of regions involved in emotion regulation, including the amygdala, hippocampus, and prefrontal cortex. These differences are present even in young people experiencing their first mood episode, suggesting they may represent risk factors rather than simply consequences of the illness. However, the differences are subtle and variable, not diagnostic markers, but clues about underlying neurobiology. What emerges from this complex picture is a model of bipolar disorder as a condition that forms through the interaction of multiple factors across developmental time. Genetic vulnerability provides the foundation. Brain development during childhood and adolescence shapes the neural architecture. Environmental stressors, sleep disruption, and substance use can act as triggers. The result is a brain whose mood regulation systems function at the edge of stability, prone to swinging toward extremes when challenged. The first mood episode often comes as a shock to the person experiencing it and to those around them. yet it represents the culmination of processes that began long before symptoms became visible. Understanding how bipolar disorder forms does not diminish its seriousness or reduce it to simple causation. The interplay of genetics, neurodevelopment, chemistry, stress, and chance creates a unique trajectory for each person. No two brains are identical, and no two paths to bipolar disorder follow exactly the same route. What unites these diverse paths is the emergence of a fundamental pattern, a brain whose capacity to regulate mood has become compromised, setting the stage for the dramatic oscillations that define the lived experience of this condition. Bipolar disorder unfolds not as a constant state but as a series of dramatic shifts, a progression through distinct phases of mood that transform perception, energy, thought, and behavior. To understand this progression is to witness one of the most striking phenomena in all of psychiatry, the human mind alternating between states so different they seem to belong to different people entirely. The condition's very name reflects this fundamental duality. Two poles of experience, opposite in nearly every dimension, yet emerging from the same underlying neurobiology. The progression typically begins with a first mood episode, most commonly occurring during late adolescence or early adulthood, though onset can happen at any age. This first episode often arrives without warning, though in retrospect, subtle signs may have been present for months or years, periods of unusual energy or creativity alternating with stretches of low mood, sleep disturbances, increasing sensitivity to stress. The first major episode can be either manic, hypomanic, or depressive, and its arrival often marks a turning point in a person's life, the moment when something previously manageable becomes unmistakably disordered. A manic episode represents one pole of the condition, a state of elevated, expansive, or irritable mood that persists for at least a week and is severe enough to cause significant impairment. During mania, the brain shifts into a mode of hyperactivity that affects nearly every domain of experience. Sleep need plummets. A person may feel fully rested after only 2 or 3 hours, or may not sleep at all for days. Energy surges to levels that feel limitless. Thoughts accelerate, racing from idea to idea faster than speech can follow. Confidence expands into grandiosity, a conviction of special powers, destiny, or abilities far beyond reality. The experience of mania is complex and often initially feels positive. Many people describe the early stages as exhilarating. Colors seem brighter, connections between ideas feel profound, creativity flows effortlessly. Social inhibitions dissolve, and a sense of possibility pervades everything. This subjective pleasure makes mania dangerous. The person experiencing it often does not recognize they are ill. Instead, they feel more alive than ever, more themselves, more capable. They may resist intervention, convinced that others simply cannot perceive the profound truths they are experiencing. But as mania progresses, the experience typically becomes less pleasurable and more chaotic. Judgment deteriorates severely. Risk-taking escalates. Financial recklessness, sexual indiscretions, reckless driving, substance use. Speech becomes pressured and difficult to interrupt. Irritability intensifies. The elevated mood gives way to agitation and anger when others do not share the manic person's enthusiasm or try to impose limits. In severe cases, psychotic symptoms can emerge: delusions of grandeur, paranoid beliefs, hallucinations. The boundary between self and reality begins to dissolve. Hypomania represents a less severe form of elevation, similar quality of symptoms but lower intensity and shorter duration, typically at least 4 consecutive days. During hypomania, energy is elevated, mood is unusually cheerful or irritable, sleep need decreases, thoughts come quickly, and productivity may increase. Crucially, hypomania does not include psychotic symptoms and does not cause such severe impairment that hospitalization is required. For some people, hypomanic episodes feel good periods of enhanced functioning and creativity. For others, even hypomania feels uncomfortable, marked more by irritability and restlessness than euphoria. The depressive pole of bipolar disorder represents the opposite extreme. During a major depressive episode, mood plummets into persistent sadness, emptiness, or hopelessness that lasts for at least 2 weeks and often much longer. Energy drains away completely. Simple tasks like showering or preparing food become overwhelming challenges. Motivation disappears. Concentration fractures. Reading a paragraph or following a conversation becomes difficult. Interest in activities that once brought pleasure evaporates. Sleep may increase dramatically, yet provides no sense of rest, or insomnia may prevent sleep entirely. The physical manifestations of bipolar depression are striking. Appetite often vanishes, leading to weight loss, or increases dramatically, leading to weight gain. Movement may slow noticeably, a phenomenon called psychomotor retardation, or restless agitation may make sitting still impossible. Chronic pain, headaches, and digestive problems often accompany the mood symptoms. The body, like the mind, enters a state of shutdown, conserving energy in a way that feels like dying by degrees. The cognitive and emotional dimensions of depression are even more devastating. Thoughts become pervaded by themes of worthlessness, guilt, and failure. The past is reinterpreted through a lens of regret. The present feels unbearable. The future appears hopeless. This is not ordinary sadness, which maintains some connection to external causes and preserves the belief that things might improve. Depressive episodes in bipolar disorder involve a fundamental alteration in how the brain processes reality itself. Every stimulus is filtered through despair. Every memory is colored by self-loathing. Every projection into the future ends in catastrophe. Suicidal thinking emerges frequently during depressive episodes. The combination of unrelenting emotional pain, hopelessness about the future, and distorted thinking creates a psychological state where death can seem like the only escape. This makes bipolar depression not just painful, but genuinely dangerous. The risk is heightened during mixed states periods when symptoms of mania and depression occur simultaneously. During mixed episodes, a person might experience the agitation and energy of mania combined with the hopelessness and despair of depression, a particularly dangerous combination that combines suicidal ideation with the energy to act on it. The progression of bipolar disorder involves not just individual episodes but patterns across time. After a first episode, the risk of future episodes is high. Without treatment, episodes typically become more frequent and more severe over time. Early in the condition's course, episodes may be triggered by identifiable stressors: loss, conflict, life transitions. As the illness progresses, episodes may arise spontaneously, without obvious external triggers. This progression suggests that having mood episodes changes the brain in ways that increase vulnerability to future episodes, a process analogous to kindling in epilepsy. Some people experience rapid cycling, a pattern where 4 or more mood episodes occur within a single year. Others have long periods of stability between episodes. Some swing primarily between depression and normal mood, experiencing few manic episodes. Others experience more mania than depression. The specific pattern varies considerably between individuals and can change over the course of a lifetime. Women may experience more depressive episodes and rapid cycling. Onset in adolescence may predict a more challenging course. Substance use worsens outcomes dramatically. Between episodes, many people with bipolar disorder return to full functioning, with no symptoms and no impairment. This is called euthymia, a state of normal, stable mood. For others, residual symptoms persist between major episodes, creating ongoing challenges even during supposedly stable periods. Cognitive effects, difficulties with memory, attention, and executive function may persist even when mood is stable, suggesting that bipolar disorder affects not just mood regulation, but broader brain function. The progression of untreated bipolar disorder is generally unfavorable. Episodes tend to increase in frequency. Relationships deteriorate under the strain of unpredictable mood shifts. Employment becomes difficult or impossible. Physical health declines due to the stress of mood episodes, sleep disruption, and often substance use or neglect of self-care. Suicide risk accumulates across the lifespan. Yet with appropriate treatment, many people with bipolar disorder achieve stability, manage symptoms effectively, and live full, meaningful lives. The condition's trajectory is not fixed. Intervention can fundamentally alter its course. Understanding this progression from first episode through the cycling patterns that follow is essential for recognizing bipolar disorder and responding appropriately. Each mood episode is not just a discrete event, but part of a larger pattern, a manifestation of underlying neurobiology that makes the brain vulnerable to extreme mood states. The challenge lies in stabilizing these fluctuations, preventing future episodes, and helping people navigate the difficult territory between two poles of human experience. The story of bipolar disorder as a recognized medical condition spans continents and centuries, weaving through the evolution of medicine itself. Long before the term bipolar was coined, long before psychiatry existed as a medical specialty, observers across cultures documented the phenomenon of human minds cycling through extremes of mood. The history of this recognition and the social responses it generated reveals as much about human societies as it does about the condition itself. In ancient Greece, the physician Hippocrates proposed that mental states arose from imbalances in bodily fluids called humors. Melancholia, he suggested, resulted from an excess of black bile, while mania stemmed from an excess of yellow bile. Though the humoral theory was scientifically incorrect, the observation was astute. Certain individuals cycled between states of profound sadness and agitated elevation. Aretaeus of Cappadocia, working several centuries later, went further, explicitly recognizing that mania and melancholia could occur in the same person, not as separate diseases, but as manifestations of a single underlying condition. These Greek insights influenced medical thinking for over 1,000 years. During the Islamic Golden Age, physicians like Avicenna and Al-Razi preserved and expanded upon Greek medical knowledge, creating comprehensive texts that described various forms of mental disturbance, including cyclical mood disorders. These works would eventually make their way back to European medical schools during the Renaissance, providing a foundation for later developments in psychiatry. Yet for most of human history, people with severe mental illnesses, including bipolar disorder, faced harsh treatment. In medieval Europe, those with unexplained behaviors were often thought to be possessed by demons or under the influence of witchcraft. Treatments ranged from prayer and exorcism to physical restraint and imprisonment. Asylums began appearing in the late Middle Ages, but these were often brutal warehouses for the mentally ill rather than therapeutic institutions. The idea that mental disorders had biological causes and might be treatable was centuries away. The 19th century brought revolutionary changes in the understanding of mental illness. The asylum movement, despite its many failings, at least recognized that people with mental disorders were ill rather than possessed or criminal. Physicians working in these institutions began carefully documenting symptoms and looking for patterns. In the middle of the 1800s, French psychiatrists Jean-Pierre Faure and Jules Bayarger independently described what they called circular insanity and double insanity, respectively, conditions characterized by alternating periods of mania and depression. The late 1800s and early 1900s saw the formalization of psychiatry as a medical discipline. Emil Kraepelin, a German psychiatrist working at the turn of the century, created a comprehensive classification system for mental disorders based on careful observation of symptom patterns and illness trajectories over time. He distinguished between what he called manic depressive insanity, characterized by episodes of mania and depression, with periods of recovery and dementia praecox, which we now call schizophrenia, characterized by progressive deterioration. Kraepelin's system recognized that manic depressive illness was fundamentally episodic, with patients often returning to normal functioning between episodes. Throughout this period of medical recognition, people with bipolar disorder lived within the constraints of their era's treatment capabilities and social attitudes. In wealthy nations, those with severe episodes might be admitted to increasingly sophisticated psychiatric hospitals. In poorer regions, families cared for affected members as best they could, often with limited understanding and few resources. Social stigma remained intense. Mental illness was associated with moral failing, weakness of character, and family shame. People often hid psychiatric conditions, and those who could not hide them faced social exclusion. The mid-20th century brought both progress and tragedy. Biological treatments emerged, first insulin coma therapy and electroconvulsive therapy, then the discovery of lithium's mood-stabilizing properties in the late 1940s, though lithium was not widely adopted until the 1970s. Simultaneously, this era saw the widespread use of prefrontal lobotomy for severe mental illness, a procedure that destroyed brain tissue and left thousands permanently disabled. The history of psychiatric treatment includes brilliant insights and devastating mistakes in equal measure. The latter half of the 20th century witnessed a revolution in both treatment and understanding. The development of additional mood stabilizers, antipsychotics, and antidepressants gave clinicians more tools to manage symptoms. Brain imaging technologies allowed researchers to observe the living brain, revealing structural and functional differences in bipolar disorder. Genetic studies demonstrated clear heritability. Public awareness campaigns began reducing stigma and encouraging people to seek help. The diagnostic criteria were refined and standardized, allowing more consistent identification across different clinicians and settings. The term bipolar disorder itself is relatively recent, introduced in the late 20th century to replace manic depressive illness. The name change reflected evolving understanding recognition that the condition involves two poles of mood extremes and an attempt to reduce the stigma associated with older terminology. The modern diagnostic system recognizes several subtypes. Bipolar I disorder, characterized by at least one full manic episode. Bipolar II disorder, characterized by hypomanic episodes and major depression but no full mania. And cyclothymic disorder, involving chronic fluctuations between mild depression and hypomania. Across cultures and continents, the recognition and treatment of bipolar disorder has varied enormously. In some societies, extreme mood states have been interpreted through spiritual or religious frameworks as possession, as divine inspiration, as punishment or blessing. In others, mental illness has been medicalized earlier and more completely. Access to psychiatric care remains profoundly unequal globally. In high-income nations with developed healthcare systems, people with bipolar disorder can often access specialized psychiatric care, medications, and therapeutic support. In low- and middle-income countries, psychiatric services may be scarce or non-existent, and people with severe mental illness may go untreated, or face abandonment and abuse. The global burden of bipolar disorder extends beyond individual suffering. Families bear emotional and financial strain. Productivity losses affect economies. Healthcare systems struggle to provide adequate services. Yet the condition also appears throughout human achievement. Looking backward through history, scholars have identified probable bipolar disorder in numerous influential figures: artists, writers, political leaders, scientists whose experiences with extreme mood states may have contributed to their creative output, even as they caused immense personal suffering. This observation has generated debate about the relationship between bipolar disorder and creativity, a connection that remains controversial and incompletely understood. The stigma surrounding mental illness, though reduced in some contexts, remains a powerful force globally. People with bipolar disorder often face discrimination in employment, housing, and relationships. Fear of disclosure prevents many from seeking treatment. Media representations frequently sensationalize mental illness or equate it with violence, despite the fact that people with bipolar disorder are far more likely to be victims of violence than perpetrators. Advocacy organizations, composed of patients, families, and allies, have worked to combat stigma and promote understanding. But changing deeply rooted social attitudes requires sustained effort across generations. The modern era has brought unprecedented scientific understanding of bipolar disorders' neurobiology, genetics, and treatment. Research continues into the specific brain mechanisms underlying mood dysregulation, the genetic variants that increase risk, and new therapeutic approaches. Global mental health initiatives aim to expand access to psychiatric care in underserved regions. Policy changes in many countries have improved mental health parity in insurance coverage and legal protections for people with psychiatric disabilities. Yet significant gaps remain between scientific knowledge and practical implementation, between available treatments and access to those treatments, between recognition of mental illness as a legitimate medical condition and the persistent social stigma that surrounds it. The human pattern that emerges from this global historical perspective is one of gradual progress punctuated by setbacks, regional variations reflecting different cultural and economic realities, and the slow accumulation of knowledge replacing superstition and fear with understanding and compassion. The journey from ancient observations of mood extremes to modern psychiatric medicine spans thousands of years and countless individual stories, people who lived with this condition across vastly different contexts, societies that responded with varying degrees of understanding or cruelty, and ultimately a growing recognition that bipolar disorder represents a medical condition deserving of scientific attention and humane treatment. In the contemporary world, bipolar disorder manifests across every demographic, geography, and social stratum. Yet the experience of the condition, how it is recognized, understood, and treated varies dramatically based on factors including healthcare access, cultural context, economic resources, and individual circumstances. To understand how bipolar disorder appears today is to recognize both universal features of the condition and the profound variability in human experiences of it. The path to diagnosis often begins with a crisis. Unlike gradual onset conditions that allow time for medical evaluation, bipolar disorder frequently announces itself through a dramatic mood episode that disrupts functioning so severely that medical attention becomes unavoidable. A college student who stops sleeping becomes convinced they have special powers and begins making reckless decisions may be brought to an emergency room by frightened friends. A middle-aged professional who has functioned well for years suddenly plunges into depression so severe they cannot get out of bed, may finally reveal to their family that this has happened before. An adolescent whose mood swings from euphoric grandiosity to suicidal despair may be referred by a school counselor to psychiatric evaluation. The experience of mania in the modern world is shaped by contemporary opportunities for harm. Credit cards enable rapid accumulation of debt during spending sprees. Social media provides platforms for impulsive posts that damage reputations and relationships. Online gambling makes it easy to lose vast sums quickly. Automobiles become weapons when driven by someone in a manic state with impaired judgment. The traditional dangers of mania, risky sexual behavior, substance use, aggression, remain present. But modern technology amplifies the potential for rapid, far-reaching consequences. For the person experiencing mania, insight is typically absent. They do not feel ill, they feel extraordinary. The world appears full of possibilities and connections invisible to others. They may believe they have discovered profound truths, developed special abilities, or been chosen for great purpose. This lack of insight makes intervention difficult. Families struggle to convince their loved one to seek treatment. Involuntary hospitalization, though sometimes necessary to prevent harm, represents a traumatic violation of autonomy. The memory of having been forcibly hospitalized, even when medically justified, can damage therapeutic relationships and discourage future help seeking. Depressive episodes present differently in terms of recognition. While the person experiencing depression lacks the energy and motivation to seek help, they typically recognize that something is wrong. The challenge with bipolar depression lies elsewhere, distinguishing it from unipolar depression. Many people with bipolar disorder experience their first major depressive episode years before any manic or hypomanic symptoms appear. When they seek treatment for depression, they may be diagnosed with major depressive disorder and prescribed antidepressants, which can sometimes trigger mania in vulnerable individuals. Accurate diagnosis often requires careful history taking to identify previous hypomanic episodes that may have been subtle or attributed to normal mood variation. The subjective experience of bipolar depression is one of profound disconnection. Activities that once brought joy feel meaningless. Relationships feel distant. The future appears as a void. Many people describe depression as a physical weight pressing down, making every movement effortful. Others describe it as numbness, an absence of feeling rather than presence of sadness. Time distorts. Hours stretch endlessly while weeks blur together. Concentration falters to the point where following a television show or reading an article becomes impossible. Decision-making, even about trivial matters, becomes overwhelmingly difficult. In contemporary society, the symptoms of bipolar disorder intersect with numerous life domains. Employment becomes challenging or impossible during acute episodes. Many people with bipolar disorder experience job loss, career interruptions, or inability to advance professionally due to episodes and residual symptoms. Financial consequences accumulate: medical bills, debt from manic spending, lost income during depressive episodes. Educational trajectories are disrupted. Students may need to withdraw during episodes, affecting academic progress and creating gaps that are difficult to explain to future employers or graduate programs. Relationships suffer under the strain of unpredictable mood shifts. Romantic partners must navigate the challenge of supporting someone whose personality can seem to transform during episodes. Parents with bipolar disorder worry about the impact on their children and the possibility of genetic transmission. Friendships fray when mood episodes cause unreliability, irritability, or withdrawal. Yet strong social support correlates with better outcomes. People with understanding, patient support networks fare better than those who face the condition alone. The challenge lies in maintaining relationships through the disruptions episodes create. Cultural context profoundly shapes the experience of bipolar disorder. In societies that emphasize individual achievement and productivity, the functional impairment of episodes may generate intense shame. In cultures with strong family bonds, the burden may be shared more broadly, but family involvement in treatment decisions can create conflicts around autonomy. Spiritual and religious frameworks may influence whether symptoms are interpreted as illness or as spiritual experiences. Stigma varies across cultures, as does willingness to engage with psychiatric treatment. Some cultures emphasize stoicism and discourage discussion of emotional struggles. Others are more accepting of mental health challenges. Access to care represents perhaps the most significant factor shaping contemporary experiences of bipolar disorder. In high-income countries with developed healthcare systems, specialized psychiatric services including psychiatrists, therapists, hospital programs, and medications are generally available, though access may depend on insurance coverage, geographic location, and systemic barriers. In middle-income countries, psychiatric care may be concentrated in urban centers while rural populations lack services. In low-income nations, psychiatric resources may be almost non-existent. People with severe mental illness may never receive diagnosis or treatment. Even where services exist, accessing them requires navigating complex systems. In many contexts, primary care physicians provide first-line mental health care, but may lack training in recognizing and managing bipolar disorder. Emergency rooms serve as psychiatric crisis centers, but focus on stabilization rather than ongoing care. Outpatient mental health services often have long waiting lists. Medications can be expensive, particularly newer agents, creating barriers for people without good insurance coverage. Therapeutic services may not be covered by insurance or may require co-payments that accumulate to unaffordable levels. The modern diagnostic process involves clinical interviews, symptom assessment, and often collateral information from family members who can describe observed behaviors during episodes. Rating scales and questionnaires help quantify symptom severity. Medical workup may include lab tests and brain imaging to rule out other conditions that can mimic bipolar disorder, thyroid disorders, neurological conditions, medication effects, substance use. Arriving at a correct diagnosis can take years, particularly for people with bipolar II disorder whose hypomanic episodes may be brief and unproblematic enough that they do not seek treatment specifically for them. The experience of receiving a bipolar disorder diagnosis elicits varied reactions. For some, diagnosis brings relief finally, an explanation for years of confusing mood shifts and difficulties. The diagnosis implies that treatment exists and recovery is possible. For others, diagnosis brings grief, fear, and anger. The recognition that one has a chronic condition requiring ongoing treatment, carrying genetic implications and social stigma, can itself be traumatic. Some people reject the diagnosis initially, either because they lack insight or because accepting it feels like accepting a diminished identity. Living with bipolar disorder in the modern world requires ongoing management. This typically involves medication, therapy, lifestyle adjustments, and monitoring for early warning signs of episodes. Many people develop sophisticated self-awareness, learning their unique patterns and triggers. They track sleep, stress, and mood. They maintain regular routines that support stability. They avoid substances and situations that increase risk. They work with healthcare providers to adjust treatments as needed. This vigilance, while burdensome, often makes the difference between repeated episodes and sustained stability. Technology has created new tools for managing bipolar disorder. Smartphone apps help people track mood, medication, and sleep. Online support communities connect people across distances. Telepsychiatry expands access to specialized care in underserved regions. Yet technology also creates new challenges. Social media can amplify mood states. Online health information varies wildly in quality, and screen time can disrupt sleep patterns critical for mood stability. The relationship between technology and mental health remains complex and evolving. The modern story of bipolar disorder is ultimately one of tremendous heterogeneity. Two people with the same diagnosis may have radically different experiences based on episode frequency and severity, symptom profile, response to treatment, support systems, and access to care. Some people achieve full remission and live without significant impairment. Others struggle with frequent episodes and chronic symptoms despite treatment. Most fall somewhere in between, experiencing periods of stability interrupted by occasional episodes, managing a condition that requires ongoing attention but does not define their entire existence. To understand bipolar disorder at its most fundamental level is to enter the realm of neuroscience, the study of how the brain generates thought, emotion, and behavior. Within the 3 pounds of tissue housed in the human skull unfolds an electrochemical symphony of staggering complexity. Billions of neurons communicate through trillions of connections, creating networks that process information, generate consciousness, and regulate every aspect of experience. Somewhere within this vast architecture lies the substrate of mood itself, and in bipolar disorder, this substrate functions differently. Mood is not localized to a single brain region, but emerges from the interaction of multiple neural circuits. At the center of mood regulation lies the limbic system, an evolutionarily ancient set of structures buried deep within the brain. The amygdala, an almond-shaped structure, processes emotional significance and threat. The hippocampus, curved like a seahorse, encodes memories and associates experiences with emotional context. The ventral striatum, part of the reward circuit, generates feelings of pleasure and motivation. These deep structures generate the raw material of emotion, the initial surge of feeling that colors our moment-to-moment experience. But raw emotion is not mood. Mood represents a sustained emotional state that persists across time and situations, coloring our perception of everything we encounter. The transformation of momentary emotion into sustained mood involves the prefrontal cortex, the brain's most recently evolved region, which sits directly behind the forehead. The prefrontal cortex exerts top-down control over the limbic system, modulating emotional responses, suppressing inappropriate impulses, and maintaining emotional states across time. In a healthy brain, this system maintains equilibrium. Sadness is proportionate to loss, joy to achievement, anxiety to threat, calmness to safety. In bipolar disorder, something about this regulatory system functions differently. The precise mechanisms remain incompletely understood despite decades of research, but a picture has begun to emerge. Brain imaging studies using magnetic resonance imaging have revealed structural differences in people with bipolar disorder compared to those without. On average, certain regions involved in emotion regulation, including the prefrontal cortex and amygdala, show subtle differences in size, structure, and connectivity. The white matter pathways that connect different brain regions may show abnormalities, potentially disrupting communication between mood regulatory circuits. Functional imaging, which measures brain activity rather than just structure, reveals how these circuits operate during mood episodes. During mania, the amygdala shows heightened activity, generating excessive emotional responses to stimuli. The prefrontal cortex, which should modulate these responses, shows reduced activity as though the brakes on emotion have failed. Reward circuits activate intensely, making everything seem more pleasurable and significant than usual. This pattern of limbic hyperactivity and prefrontal hypoactivity creates the subjective experience of mania. Intense emotion, poor judgment, and amplified responses to reward. During depression, a different pattern emerges. The prefrontal cortex shows reduced activity, particularly in regions involved in motivation and positive emotion. Reward circuits become sluggish, unable to generate pleasure even from normally rewarding experiences, a phenomenon called anhedonia. The amygdala may show either increased or decreased activity depending on the specific subtype of depression, but its communication with the prefrontal cortex is disrupted. The overall pattern is one of reduced connectivity between brain regions, as though the networks that should work together to generate normal mood have become disconnected. These brain activity patterns arise from chemistry, specifically from neurotransmitters, the chemical messengers neurons use to communicate. When an electrical signal travels down a neuron, it triggers the release of neurotransmitter molecules into the tiny gap between neurons called the synapse. These molecules cross the gap and bind to receptors on the receiving neuron, either exciting it to fire or inhibiting its activity. The entire dance of thought and emotion reduces at one level to patterns of neurotransmitter release, diffusion, binding, and recycling. 3 neurotransmitter systems are most strongly implicated in bipolar disorder. Dopamine, released by neurons in the midbrain, travels to multiple brain regions where it influences motivation, reward, pleasure, and movement. In mania, dopamine signaling appears excessive, creating the intense goal-directed behavior, elevated mood, and increased pleasure that characterize the manic state. In depression, dopamine signaling appears insufficient, contributing to anhedonia, lack of motivation, and psychomotor changes. The dopamine system may be fundamentally unstable in bipolar disorder, swinging between extremes rather than maintaining steady output. Serotonin, released by neurons in the brainstem's Raphi nuclei, influences mood, impulse control, sleep, and appetite. Serotonin abnormalities have been implicated in both mania and depression, though the nature of these abnormalities remains debated. Low serotonin may contribute to depression and impulsivity. Dysregulated serotonin may contribute to mania. Many medications used to treat bipolar disorder affect serotonin signaling, though whether they work primarily through serotonin effects or through other mechanisms remains unclear. Norepinephrine, also called noradrenaline, functions both as a neurotransmitter in the brain and as a hormone in the body. It regulates arousal, attention, and the stress response. Excessive norepinephrine signaling may contribute to the agitation, reduced need for sleep, and racing thoughts of mania. Insufficient norepinephrine may contribute to the low energy and concentration problems of depression. The norepinephrine system connects emotional states to physical arousal, helping explain why mood episodes in bipolar disorder involve not just psychological changes, but profound alterations in energy, sleep, and bodily sensations. Beyond these classical neurotransmitters, other signaling systems appear involved in bipolar disorder. Glutamate and GABA, the brain's primary excitatory and inhibitory neurotransmitters respectively, may be dysregulated. The balance between excitation and inhibition, the brain's fundamental mechanism for maintaining appropriate activity levels, may be disturbed. Some research suggests that abnormalities in how neurons generate energy or respond to stress may contribute to vulnerability. The neuropeptide systems that modulate neurotransmitter function may operate differently. What emerges is a picture not of a single chemical imbalance, but of multiple systems operating outside their normal parameters. Circadian rhythms, the internal biological clocks that regulate sleep-wake cycles, and numerous physiological processes are profoundly disrupted in bipolar disorder. The suprachiasmatic nucleus, a tiny region in the hypothalamus, serves as the brain's master clock, synchronizing bodily rhythms to the day-night cycle. This clock regulates not just sleep, but also hormone release, body temperature, metabolism, and mood. In bipolar disorder, circadian rhythms become desynchronized. During mania, the clock speeds up, sleep need plummets, activity increases, and the brain operates as though in perpetual daytime. During depression, the clock may slow or become erratic, creating the sleep disturbances that plague depressive episodes. The relationship between sleep disruption and mood episodes is bidirectional and powerful. Sleep deprivation can trigger mania in vulnerable individuals. Indeed, even a single night of missed sleep can precipitate a manic episode in someone with bipolar disorder. Conversely, manic episodes severely disrupt sleep, creating a vicious cycle. Similarly, depression disrupts sleep architecture, and poor sleep worsens depression. The circadian system and mood regulation appear intimately linked, suggesting that treatments targeting sleep and circadian rhythms might help stabilize mood. An important concept in understanding the neurobiology of bipolar disorder is neuroplasticity, the brain's ability to change its structure and function in response to experience. Having mood episodes appears to change the brain in ways that make future episodes more likely. Early episodes often require clear triggers, but later episodes may arise spontaneously. Brain imaging studies suggest that repeated episodes are associated with progressive changes in brain structure. This phenomenon, called neuroprogression or kindling, suggests that bipolar disorder is not static, but evolves over time, with each episode potentially altering the brain's vulnerability to future episodes. Stress plays a crucial role in the neurobiology of bipolar disorder through its effects on multiple systems. The hypothalamic pituitary adrenal axis, the body's primary stress response system, releases cortisol during stress. Chronic elevation of cortisol affects the hippocampus, amygdala, and prefrontal cortex, the very regions involved in mood regulation. Stress also affects neurotransmitter systems, immune function, and neuroplasticity. In people with bipolar disorder, the stress response may be dysregulated, either overreacting or failing to shut off appropriately, contributing to mood destabilization. Inflammation has emerged as another biological factor in bipolar disorder. Mood episodes are associated with increased levels of inflammatory markers in the blood and cerebrospinal fluid. Chronic inflammation affects neurotransmitter synthesis, damages neurons, and disrupts neural circuits. Some researchers propose that bipolar disorder involves a neuroinflammatory component, with activated immune cells in the brain releasing signals that disrupt normal neural function. This finding has generated interest in anti-inflammatory approaches to treatment, though research is still in early stages. Genetic factors influence all of these biological systems. The numerous genes associated with increased risk of bipolar disorder affect diverse aspects of brain function: neurotransmitter receptors, ion channels that regulate neuronal excitability, proteins involved in circadian rhythms, factors controlling neuroplasticity, and components of stress response systems. The cumulative effect of genetic variations across these systems creates a brain that is more vulnerable to mood dysregulation when challenged by environmental stressors. What happens inside the brain during bipolar disorder is ultimately a story of dysregulation systems that should maintain homeostasis instead swing toward extremes. The neural circuits that generate emotion become too active or too quiet. The neurotransmitter systems that should provide stable signaling instead fluctuate wildly. The circadian rhythms that should entrain to the environment become desynchronized. The stress response systems that should activate briefly, then return to baseline, instead remain chronically elevated or fail to activate appropriately. The prefrontal cortex that should exert top-down control over emotion instead loses its modulatory influence. This neurobiological perspective does not reduce bipolar disorder to simple mechanical failure. The brain is not a machine with broken parts, but a living, adaptive system whose complexity defies complete explanation. Neuroscience provides insights into mechanisms, identifies targets for treatment, and gradually illuminates the biological basis of mood dysregulation. Yet understanding the neurobiology does not fully capture the lived experience of bipolar disorder, the subjective reality of consciousness transformed by mood states, the struggle to maintain identity across dramatic shifts in perception and emotion, and the human meaning of living with a brain whose chemistry creates both extraordinary capacities and profound vulnerabilities. Living with bipolar disorder extends far beyond the acute drama of mood episodes. The condition creates ripples that spread through every dimension of life, affecting physical health, cognitive function, relationships, economic stability, and fundamental sense of self. To understand the full weight of bipolar disorder requires examining not just the episodes themselves, but the cumulative burden of a chronic condition that demands lifelong management and extracts significant costs, even during periods of remission. The cognitive effects of bipolar disorder persist even between mood episodes, creating subtle but consequential impairments. Many people with the condition experience ongoing difficulties with attention, concentration, memory, and executive function, the high-level cognitive abilities that allow us to plan, organize, solve problems, and control impulses. These cognitive symptoms, sometimes called cognitive residuals, affect the ability to perform complex work, manage multiple responsibilities, and function at one's full potential. For someone working in a cognitively demanding profession, these subtle impairments can significantly affect career trajectory and earning potential. The mechanisms underlying cognitive impairment in bipolar disorder remain incompletely understood, but likely involve multiple factors. Mood episodes themselves may cause temporary cognitive disruption that does not fully resolve. Medications used to treat the condition can affect cognition, particularly attention and processing speed. The stress of managing a chronic illness affects cognitive performance. Chronic sleep disruption takes a cumulative toll on brain function. Inflammatory processes associated with mood episodes may damage neural circuits. Whatever the mechanisms, the result is that many people with bipolar disorder find themselves unable to perform cognitively at the level they achieved before illness onset. Physical health complications accumulate over time in people with bipolar disorder, creating a paradox, a psychiatric condition with profound effects on bodily health. Cardiovascular disease occurs at higher rates and earlier ages in people with bipolar disorder compared to the general population. This increased risk reflects multiple factors. Some medications used for treatment can cause weight gain and metabolic changes. Depression and mania both involve stress responses that affect the heart and blood vessels. Health behaviors during episodes often deteriorate, and shared genetic factors may increase risk for both bipolar disorder and cardiovascular problems. Metabolic syndrome, a cluster of conditions including obesity, high blood pressure, elevated blood sugar, and abnormal cholesterol, occurs at alarming rates in people with bipolar disorder. Some of this risk stems from medications, particularly certain mood stabilizers and antipsychotics that can cause significant weight gain and metabolic disturbances. But behavioral factors also contribute. Physical activity often decreases during depressive episodes, and judgment about diet may be impaired during mania. Over decades, these metabolic disturbances increase risk for diabetes, heart disease, and stroke, contributing to reduced life expectancy in people with bipolar disorder. The relationship between bipolar disorder and substance use creates another layer of health complications. People with bipolar disorder have elevated rates of alcohol and drug use compared to the general population. Substance use may represent attempts to self-medicate mood symptoms, social factors associated with mental illness, impaired judgment during episodes, or shared genetic vulnerability. Whatever the reasons, substance use disorders worsen the course of bipolar disorder, trigger more frequent mood episodes, impair medication effectiveness, damage physical health, and create additional social and occupational problems. The economic burden of bipolar disorder extends to individuals, families, and society. During acute episodes, work becomes impossible, creating lost wages and risk of job loss. Even during stable periods, cognitive symptoms and fear of relapse may limit career advancement. Medical costs accumulate. Psychiatric medications, doctor visits, therapy sessions, hospitalizations during acute episodes, and treatment of physical health complications. In many healthcare systems, mental health services are less well covered by insurance than other medical services, creating significant out-of-pocket expenses. Debt from manic spending sprees adds to financial strain. For families, the burden includes both direct caregiving and indirect effects. Partners may need to assume larger share of household responsibilities during episodes. Children of parents with bipolar disorder may experience disrupted parenting, anxiety about their parents' health, and genetic risk of developing the condition themselves. Family members often reduce work hours or leave employment to provide care during acute episodes. The emotional toll on families is substantial. Worry about their loved one's safety, grief over changes in the person they know, exhaustion from years of crisis management, and their own mental health effects from chronic stress. Relationships face particular challenges when one person has bipolar disorder. The unpredictability of mood episodes creates uncertainty that strains even strong partnerships. During mania, behavior may become hurtful, reckless, or frightening. During depression, emotional availability disappears, and the person may become withdrawn or irritable. Between episodes, the relationship must adapt to medication effects, therapy schedules, lifestyle restrictions needed for stability, and the persistent fear of the next episode. Many romantic relationships do not survive these strains, creating patterns of relationship instability that further complicate life with bipolar disorder. Social isolation emerges as both a consequence and a complication of bipolar disorder. During depressive episodes, people withdraw from social contact. During manic episodes, behavior may alienate friends. Between episodes, shame about past actions during episodes, fear of judgment, and the energy required to maintain relationships while managing illness create barriers to social connection. Yet social isolation itself worsens outcomes. People with strong social support fare better than those who face the condition alone, creating a tragic irony where the illness drives away the very support that could help stabilize it. Stigma remains a powerful force shaping the experience of bipolar disorder despite increased mental health awareness. People with the condition face discrimination in employment, with employers reluctant to hire or promote someone with a psychiatric history. Housing discrimination occurs, with landlords refusing to rent to people with mental illness. Social stigma manifests in distancing behaviors, uncomfortable reactions to disclosure, and assumptions about dangerousness or unreliability. Internalized stigma, where people absorb negative societal attitudes about mental illness, affects self-esteem and may discourage treatment seeking. The impact on sense of self represents perhaps the most profound consequence of bipolar disorder. Identity formation typically occurs during adolescence and young adulthood, precisely when bipolar disorder most commonly emerges. The person must integrate a chronic mental illness into their developing sense of who they are. Questions arise: am I my illness, or am I a person who has an illness? Which aspects of my personality are authentic, and which are symptoms? Who would I be without this condition? These existential questions do not have simple answers, and struggling with them is part of the work of living with bipolar disorder. For some people, bipolar disorder becomes inextricably linked with creativity, productivity, and aspects of identity they value. The heightened perception and creative drive that can accompany hypomania may feel like accessing their truest self. Treatment that eliminates mood elevation may feel like losing something essential, creating ambivalence about full symptom control. This phenomenon occurs particularly in people whose creative or professional success has been linked to hypomanic periods, creating conflicts between health and identity. Suicide represents the most tragic outcome of bipolar disorder. People with the condition face dramatically elevated lifetime risk of suicide compared to the general population. The risk is highest during depressive and mixed episodes, when the combination of emotional pain, hopelessness, and impaired thinking creates dangerous vulnerability. Previous suicide attempts, substance use, recent loss, social isolation, and access to means all increase risk. Family history of suicide, which is itself elevated in families with bipolar disorder, further increases vulnerability. Preventing suicide in people with bipolar disorder requires vigilant monitoring, effective treatment, crisis planning, and restriction of access to lethal means during high-risk periods. The impact of bipolar disorder on parenting creates additional layers of complexity and concern. Parents with bipolar disorder worry about the genetic risk they have passed to their children and about the impact of their symptoms on their children's well-being. During depressive episodes, parents may struggle to provide adequate care and emotional availability. During manic episodes, judgment about child safety may be impaired. Children growing up with a parent who has bipolar disorder face increased stress and, depending on family circumstances, may develop their own mental health difficulties. Yet many parents with bipolar disorder, particularly those with good treatment and support, raise healthy, resilient children. The cumulative burden of living with bipolar disorder over decades affects not just specific life domains but overall quality of life. Repeated episodes, chronic symptoms, medication side effects, social losses, economic difficulties, and health complications accumulate into what researchers call disease burden. This burden varies enormously between individuals based on episode frequency and severity, treatment response, social support, economic resources, and access to care. For some, bipolar disorder remains relatively well controlled with minimal impact on functioning. For others, it creates severe, lifelong disability. Global disparities in bipolar disorder outcomes reflect broader inequalities in healthcare access and social resources. In high-income countries with developed mental health systems, many people with bipolar disorder achieve good outcomes with appropriate treatment. In low- and middle-income countries where psychiatric services are limited, outcomes are often much worse. Lack of access to medications, shortage of trained mental health professionals, greater stigma, and fewer social safety nets all contribute to poorer outcomes. These disparities remind us that the burden of bipolar disorder is not simply biological, but deeply shaped by social and economic contexts. The long-term perspective on bipolar disorder must balance honesty about challenges with recognition of possibilities for good outcomes. The condition is serious, chronic, and burdensome. It requires ongoing treatment and vigilance. It creates risks and limitations. Yet it is also treatable, and many people with bipolar disorder live full, meaningful, productive lives. They form lasting relationships, pursue careers, raise families, contribute to their communities, and find ways to thrive despite or sometimes because of their experiences with extreme mood states. The burden is real, but it is not the entire story. We return, finally, to where we began. The fundamental mystery of bipolar disorder, why this pattern exists, what it means, and what it reveals about the human condition. The journey through the science of this disorder has taken us from ancient observations to modern neuroscience, from individual neurons to global health systems, from acute episodes to lifelong trajectories. Now we must step back and consider the larger context, what bipolar disorder teaches us about the brain, about evolution, about creativity and suffering, and about what it means to be human. The relationship between bipolar disorder and creativity has fascinated researchers, clinicians, and the public for generations. Historical analyses suggest that rates of bipolar disorder, particularly the milder bipolar II type, may be elevated among accomplished artists, writers, composers, and other creative professionals. Contemporary studies find associations between hypomania and enhanced creative productivity. The features of hypomania, increased energy, rapid thought, heightened perception, reduced inhibition, willingness to take risks, overlap considerably with psychological states that facilitate creative work. Yet this relationship is complex and easily misunderstood. Bipolar disorder does not cause creativity. Most people with the condition are not unusually creative, and most creative people do not have bipolar disorder. Rather, there may be a subgroup of people in whom genetic factors that increase risk for bipolar disorder also influence temperament and cognitive style in ways that, under certain circumstances, facilitate creative achievement. The hypomanic state itself may enhance productivity and allow unusual cognitive connections, but full mania impairs rather than enhances creative work, and depression prevents creative productivity altogether. The cultural romanticization of the connection between mental illness and creativity can be harmful. It may discourage people from seeking treatment, fearing they will lose their creative edge. It may minimize the suffering associated with bipolar disorder by framing it as a worthwhile price for artistic achievement. It may create pressure for people with bipolar disorder to be creative, as though this would justify their suffering. The reality is that for most people with bipolar disorder, treatment improves rather than impairs functioning across domains, including creative work, by reducing the time lost to debilitating episodes. What bipolar disorder reveals most clearly is the brain's capacity for extreme states. The neural systems that regulate mood can, under certain conditions, generate experiences far outside the normal human range. During mania, consciousness can expand into grandiosity, perception can intensify until ordinary objects seem laden with cosmic significance, and confidence can swell to delusional proportions. During depression, the same brain can create a subjective reality of unrelenting despair, where meaning dissolves and the future appears as an endless void. That these opposite extremes can both emerge from one brain illuminates the extraordinary plasticity and range of human consciousness. The evolutionary question remains: why has natural selection preserved genetic variants that increase risk for a condition as harmful as bipolar disorder? Several hypotheses have been proposed. Perhaps the genetic factors that increase risk for bipolar disorder, when present in lower doses, provide advantages without causing illness, increased energy, creativity, social dominance, or resilience. Perhaps the genes involved have other functions that are beneficial, with increased bipolar risk as an unavoidable side effect. Perhaps in ancestral environments, the pattern we now call bipolar disorder was less maladaptive than it is in modern society. Another possibility is that there is no adaptive explanation, that bipolar disorder simply represents the inevitable variation that arises in any complex biological system. The human brain is fantastically complex, assembled through developmental processes influenced by thousands of genes and countless environmental factors. With such complexity, some degree of dysfunction is statistically inevitable. Not every pattern of variation needs an adaptive explanation. Some may simply reflect the limits of biological systems to maintain perfect function across variable conditions. Modern treatment of bipolar disorder represents one of psychiatry's success stories, though significant room for improvement remains. Mood stabilizers, particularly lithium, can dramatically reduce episode frequency and severity in many people. Anticonvulsants offer alternatives for those who cannot tolerate lithium. Antipsychotic medications treat acute mania and prevent relapse. Antidepressants, used carefully in combination with mood stabilizers, can address bipolar depression. Psychotherapy, particularly focused approaches that help people recognize early warning signs and maintain stabilizing routines, enhances outcomes when combined with medication. Yet treatment is far from perfect. Many people do not respond adequately to available medications. Side effects limit tolerability. The need for ongoing medication adherence, often for life, poses challenges. No treatment prevents all future episodes. The search for better treatments continues, focusing on novel mechanisms of action, personalized medicine approaches that match individuals to the treatments most likely to help them, and interventions targeting the underlying neurobiology more precisely. Research continues to advance understanding of bipolar disorder's biological basis. Genetic studies are identifying specific genetic variants and biological pathways involved in risk. Brain imaging research is revealing the neural circuits and connectivity patterns that differ in bipolar disorder. Studies of circadian rhythms, inflammation, neuroplasticity, and other biological systems are expanding the framework for understanding mood dysregulation. Animal models are providing insights into mechanisms that cannot be studied directly in humans. All of this research aims toward more effective, targeted, and personalized treatments. The lived experience of bipolar disorder, beyond the neuroscience and epidemiology, is ultimately a human story. It is the story of people navigating a condition that transforms their relationship with their own mind. It is families learning to support someone they love through terrifying episodes while maintaining boundaries and protecting their own well-being. It is healthcare providers working to treat a complex condition with imperfect tools. It is researchers pursuing questions at the frontier of neuroscience. It is societies learning to respond to mental illness with compassion rather than stigma. Many people with bipolar disorder develop remarkable resilience through their experiences. They learn to recognize subtle shifts in mood and intervene before full episodes develop. They become experts in their own condition, understanding their unique patterns and triggers. They develop sophisticated coping strategies. They find meaning in their experiences, sometimes using their struggles to help others facing similar challenges. This resilience does not negate the suffering the condition causes, but it demonstrates the human capacity to adapt and find strength even in the face of severe illness. The disability community and mental health advocacy movements have worked to reframe bipolar disorder from a purely medical problem to a dimension of human diversity. While recognizing that the condition causes suffering and requires treatment, this perspective emphasizes that people with bipolar disorder have value, rights, and contributions beyond their diagnosis. It challenges discrimination and fights for accommodation rather than exclusion. It insists that people with mental illness can speak for themselves about their experiences and their needs. The future of bipolar disorder care will likely involve multiple fronts of progress. Better medications with fewer side effects and greater efficacy will help more people achieve stable mood. Improved diagnostic tools may allow earlier identification and intervention before the condition becomes entrenched. Digital technologies may enable better monitoring and support between clinical visits. Reduced stigma will encourage earlier help seeking and better social support. Policy changes may improve access to care and protect people with mental illness from discrimination. Ultimately, bipolar disorder stands as a profound example of the brain's capacity for dysfunction in the service of illuminating function. By studying what goes wrong in bipolar disorder, how mood regulation fails, how neural circuits become dysregulated, how genetic and environmental factors interact, neuroscience learns about the normal mechanisms of emotion and mood. Every condition, in a sense, is an experiment of nature, providing insights into biological systems that would be impossible to obtain otherwise. The journey through the science of bipolar disorder circles back to our beginning question: why does this pattern exist? Perhaps the answer is that the same neural complexity that enables human consciousness, emotion, creativity, and meaning also creates vulnerability to their dysregulation. The systems that allow us to feel profound joy can fail into mania. The systems that help us respond to loss can fail into unrelenting depression. The capacity for extreme states may be inseparable from the capacity for the full range of human experience. We stand at a moment in history where understanding of bipolar disorder is deeper than ever before, yet still incomplete. We have effective treatments, yet they help imperfectly. We have reduced stigma, yet it persists. We have opened conversations about mental health, yet silence remains common. The story of bipolar disorder is ongoing in laboratories where researchers pursue new knowledge, in clinics where providers work to help patients stabilize their lives, in homes where families navigate the challenges the condition creates, and in the minds of people who live with this pattern every day. The complete science of bipolar disorder encompasses neurobiology and genetics, psychology and sociology, history and anthropology, suffering and resilience, loss and hope. It is a story about the brain's extraordinary complexity and its vulnerability to dysfunction. It is a story about the human search for understanding, for treatment, and for meaning in the face of illness. Most of all, it is a reminder that mental health and mental illness exist on a continuum, that the systems enabling our highest capacities also create our deepest vulnerabilities, and that understanding and compassion remain essential as we navigate the complexities of human consciousness in all its manifestations. The electrical storm contained within the skull continues. Neurons fire, chemicals flow across synapses, circuits activate and inhibit. From this biology emerges the full spectrum of human experience: joy and despair, connection and isolation, meaning and emptiness, stability and chaos. For those whose brains generate the pattern we call bipolar disorder, the storm sometimes grows wild, sweeping consciousness toward extremes. Yet within that storm, as in all human minds, lies something irreducible. A person experiencing, adapting, struggling, enduring, and ultimately asserting their humanity in the face of forces they did not choose and cannot fully control.